So for those of you that don't know my voice, it's Adira Levin, and I'm one of the co-investigator leads of CanSolve CKD, and I'm really excited to be able to welcome you to our third installment of this CanSolve CKD webinar series. For those of you that haven't done webinar, it gives you a chance to hear in real time and watch the slides in real time on your computers as our various investigators and patient partners present their work and ideally for interaction. So what we're trying to do is showcase all of the projects and all of the activities that we're doing in CanSolve so that everyone understands what's going on around the country. And, you know, there are different ways to do this, and this is one that so far has met with a fair amount of excitement. It's also an important way that you can ask questions and get some discussion going. We make the presentations pretty short, and then we use the rest of the time to make sure that if you have questions, Joanne and others can answer them. So if you have a question during the presentation, you can either enter it into the little chat window that you see for those of you on the computer on the WebEx, and then we'll actually collect them and give you the answers during that Q&A that we have afterwards. If you want to ask a question during the presentation, then you can enter it in the chat window, or you can raise your hand button next to your name, and then the presenters will be able to see it. The next thing I just want to remind everybody is that the webinar is recorded and will be archived on our website, so you can, and once we're done, we circulate the link, and then you'll be able to go and look at it at your leisure if you want to refresh your memory. So I'm going to hand it over to Joanne and just give you a bit of a background, because today's presentation is going to focus on improving patient knowledge about treatment options and a project. And Joanne's going to present the project in the context of decision-making around complex decisions, different ways to support people, the way they get information, and how we can actually better understand all the barriers that face people with kidney disease and create a proper or a best-in-kind educational program. So, Joanne, can I turn it over to you, and then we can get on with it? Is that all right?
Yep, certainly. Thank you very much, Adira. So beside me is Jack Hicks. He is our research manager for this project. And the project is really improving Indigenous patient knowledge about treatment options for failing kidneys. My co-presenter today was going to be our elder, George Laliberte, but unfortunately, 2 days ago he fell and has likely fractured his ankle, and so presently is now seeing the orthopedic surgeon. And he expresses his regret that he could not be here. But he was very instrumental in helping us prepare this presentation, and has been a great source of support and knowledge about Indigenous protocol and procedure for our project. So Graham, next slide, please. So just to orientate people, much like the last webinar that you saw, there are three themes in CanSolve, and we happen to be in theme 3, which is defining optimal ways to deliver patient-centered care in the 21st century. So we're improving, the short title there is Improving Patient Knowledge About Treatment Options, but the project has limited itself to Indigenous patient knowledge about kidney failure. Next slide, please. So there is an oversight committee because this project actually will take place in 3 provinces: British Columbia, Saskatchewan, and Ontario. So the oversight committee chairs are the principal investigators, co-principal investigators are Dr. Bev Horsberg, who could not be here today. She's the interim dean of nursing at the University of Saskatchewan, and we had a budget coming down from the provincial government today that she had to be at a budget meeting. And then myself as the co-chair, and I am from the University of Saskatchewan as well. The BC subcommittee will be chaired by Monica Beaulieu, who is a nephrologist at St. Paul's Hospital, Vancouver. The Saskatchewan subcommittee is chaired by Dr. Carol Boleyn, who is a nursing professor at the University of Saskatchewan. And the Ontario subcommittee, we're just sort of in negotiations with the Division of Nephrology in Thunder Bay and the College of Nursing at Lakehead University in Thunder Bay. So our presentation today really will be focusing, though, on the Saskatchewan subcommittee, but whatever we're doing here will be replicated in the other two provinces. Next slide, please. So our research question then, as Dr. Levin had alluded to, is that when an individual's kidneys fail, how does the Indigenous patient's healthcare team best support patient and family decision-making regarding the treatment options for failing kidneys? So that is the background. So next slide, please. So the co-investigators, as I said, is Dr. Beth Horsburgh and myself. We have Elder George Laliberte, who is a Métis person from Beauval, which I will show you on a map coming up. Our team members are Dr. Carol Boleyn, Dr. Jeffrey Mena, who is a assistant nursing professor at the College of Medicine in Prince Albert, actually. Dr. Lynn Jensen, who is a nursing professor at the University of Saskatchewan. She's based in Regina. Dr. Margaret Kovac, who is a education professor, who is an Indigenous woman with a lot of knowledge and a lot of experience in Indigenous teaching. Sharon Clark, who is with the First Nations and Métis Health Branch of the Saskatoon Health Region, is an Indigenous woman who is helping us with this project as well. Dr. Charlene Haber, who is with the College of Medicine. She's with the Saskatchewan Support Unit, the Skipper Support Unit, and she is a methodology expert. Dr. Catherine McLeod, who was a methodologist with the Saskatchewan Support Unit, is now at the School of Medicine in Connecticut, but she has been very instrumental at the beginning of this project and wishes to continue. She has lots of knowledge to contribute to us. And then our research manager, Jack, who is sitting beside me. Next slide, please. So our approach is to engage with two Indigenous communities which have high rates of chronic kidney disease in Saskatchewan. And in addition to having Indigenous persons on our oversight committee, which I'm hoping will be Mary Bopage and Helen Sete, and Elder George Laliberte, who is advising the Saskatchewan team, all of the people that will be on the study group are community residents who are either Métis or Indigenous. So there'll be community residents that have chronic kidney disease and or their families, and they will be serving as our patient partners. Next slide, please. So this is a slide of Saskatchewan, if you haven't figured that out. And you see our project base is Saskatoon. Our population is about 300,000. And the University of Saskatchewan is actually situated on Treaty 6 territory and home of the Métis. So, and our study community 1 is Isla Cross, which you can see on the my left-hand side of the slide. Its population is about 1,300. It's mostly Métis, but there are a lot of Cree and Dene people in the surrounding communities. Isla Cross is a 5.5-hour drive from Saskatoon. We'll talk about Isla Cross in a second. The second study community is La Ronge. La Ronge has the town of La Ronge has a population of about 2,700, but there are multiple reserves around La Ronge, and so therefore the population of the La Ronge area is roughly about 6,000, and it's primarily Indigenous in nature. So La Ronge is a 4.5 to 5-hour drive from Saskatoon. Next slide, please. So this here is Isla Cross. So Isla Cross is situated on this very beautiful lake. And on one part of the slide here, you'll see St. Joseph's Health Center. It's a very beautiful facility that's actually connected to the school, and so they share some of the facilities together. It's a small hospital, but it provides a lot of care for people around the north. There's a welcoming sign which has the mallard duck, and then you see a picture of some individuals, not necessarily from Isle of Cross area. And what you see on the top there is that little spit of land where the community of Isle of Cross is situated. And so as you go up the road, you take the long road around to come to Saskatoon. However, when we went to visit Isle of Cross in February, our intrepid Jack Hicks and Elder George decided to take Carol and I across the ice road against, and we were not happy. We made them take us back the long way when we came back. So this is one of the communities. This is, as I say, the primarily Métis community. Next slide, please. And then these are some pictures of L'Orange. Again, the welcome sign to L'Orange. And what you see at the bottom there is the robot. The robot is used by the College of Nursing to teach nursing students that are based in L'Orange. And so that robot may be some of the ways that we are going to be engaging with the L'Orange community and Isle of Cross. Isle of Cross has a robot as well because the nursing college teaches nursing students, Indigenous nursing students, both in Isle of Cross and L'Orange. And you can see at the top of the page, again, a community along the shores of a massive lake. They have a very new health facility there, a very progressive chief of the Lac L'Orange Indian Band. A beautiful place. I would highly encourage people to go to both Isle of Cross and L'Orange on holidays because it is stunning.
And very good fish.
And Jack says very good fish. I don't know, I'm a vegetarian, so I don't eat fish. So next slide, please. So our approach is respecting the recommendations from the Truth and Reconciliation Commission of Canada. And there are several health-related TRC recommendations, and the three that our project will be involved with are TRC recommendation 19, 20, and 22. And so how our project will look at the TRC recommendations are, the first one is to measure measurable goals to identify and close the gaps in health outcomes. So for developing then teaching materials about end-stage kidney disease will certainly hopefully close the gap between knowledge of health literacy, et cetera, between First Nations and non-First Nations communities. The number 20 is recognizing, respecting, and addressing the distinct health needs of Métis, Inuit, and off-reserve Aboriginal peoples, and we hope that that will be addressed as well once we've developed the tools and then taken them to other communities for understanding and usefulness. And the last TRC recommendation is to recognize the value of Aboriginal healing practices and use them in the treatment of Aboriginal patients in collaboration with Aboriginal healers and elders where requested. So I am hoping that when we're developing, co-developing these tools with these two communities, Isle of Cross and L'Orange, that we will be embedding traditional healing practices from the First Nations and Métis cultures. Next slide, please. So with this, I'm going to turn it over to Jack. These next few slides were what Elder George was going to present, but unfortunately could not, as I said. George? Or Jack?
Thank you, Joanne. Okay, so I wanted to talk about two things on behalf of Elder George. The first is the concept of Miyaoyowin, which is a Cree term could translate as getting better or achieving wellness. And it's kind of the central symbol for our project. And Elder George has helped us develop and implement this concept in the project. And the goal is to situate our project within Indigenous cultural perspectives of health and wellness. So the goal of our work is to co-develop educational tools which will help to contribute to providing a healthy environment in which to foster, develop, and strengthen individual health and relationships between people through culturally relevant approaches. And that will become more clear with the next slide, please. So the basic idea is that we can think of there being two culturally determined perspectives on health. One is what we could call the Prairie Indigenous worldview, and the other the Western worldview. And the project views both of these worldviews as meaningful and of value, of significance, and each provides people with health literacy that reflects the values of the two societies. The idea being that we need to bridge the two in a way that enables two-eyed seeing, that allows the Indigenous people to understand the Western system and the Western system to understand the Indigenous system. This process will result in the development of tools, culturally appropriate tools that will be tested both for how they work in the Indigenous communities as measured by the Indigenous people that we will be working with, but they also have to work with the largely Western service providers in the communities. And the tools must be deemed useful by both parties for optimum sharing between the cultures and also beyond the original community. The point being there that tools that are developed in one community may need adaptation to work in another community because the different Indigenous societies are quite different, one to another, and the goal is not to attempt to develop a one-size-fits-all Indigenous toolkit, but rather to develop understandings and approaches which can then be modified with the assistance of people on the ground in different communities to be relevant to other communities than the ones that we began the work in. Next slide, please. So underlying all this is the concept of the medicine wheel and a four directions approach. So the medicine wheel has been used since time immemorial by First Nations people across North America. It embodies the four directions as well as the concepts of Father Sky, Mother Earth, and the Spirit Tree, which symbolize dimensions of health and the cycles of life. If you Google medicine wheel, you would see that there are dozens, possibly hundreds, of different graphic representations of the medicine wheel reflecting different perspectives of different First Nations. So it's an approach that is common to a lot of First Nations societies, but there isn't a homogeneous one-size-fits-all understanding of the concepts. Rather, it's an approach that different First Nations work with. Even the colors change in different communities. So when we're approaching a community, care must be taken to respectfully approach the elders in that community and how they wish the overall concept of the medicine wheel to be incorporated in the design of a project in their community. Next slide, please. So this is the approach that we're using in the first community that we're working in, the largely Métis community of Isle La Crosse, which incidentally is the second oldest settlement in the province. It's where Louis Riel's sister is buried. Has a remarkably long history. In the health center, there's a page from an Oblate magazine in which it was referred to as the Bethlehem of the North because it had the first of any kind of health facilities in northern Saskatchewan. So the text from Elder George are in quotations, which he approved. This is explicitly the message he asked to have delivered. We start in the east where the sun rises in the morning, and then we work clockwise around the wheel. Only when we have moved together through the first three dimensions can we truly address the body physical dimension. In other words, discussions and process starts with the yellow mind social domain of interaction, moves to the soul spiritual dimension, then onto a different form of the mind social dimension, and only then to the body physical dimension. We don't just immediately start talking about the body physical dimension. Next slide, please. So these are the key messages that Elder George wanted to share with you. That all cultures have wisdom and knowledge to share, but Western culture has not always been willing to respect Indigenous wisdom and knowledge. As a result, Indigenous cultures have been misunderstood and misrepresented. The missionaries, the residential schools, the 60s scoop, the jails, diabetes, is all part of that. This is why Indigenous peoples watch and hear when outside experts and researchers come to our communities, but we don't really listen to them. It's only when Indigenous people sense respect and sincerity that they're willing to really listen to experts and researchers and truly engage with them.
Next slide, please. So our design is an educational development with designated Indigenous communities, Isla Crosse and L'Orange. We'll have a mixed methods approach where we're doing qualitative interviews and quantitative analysis. It will be with sharing circles, with individual interviews, work groups, etc. Our population are Indigenous men and women who are age 18 and above, who have stage 4, stage 5 chronic kidney disease, likely not yet on dialysis, although our team has been discussing that we would likely include people within the first year of dialysis, because we would like to say to them, well, what would you have wanted to know that you didn't know after you started your dialysis journey? And certainly family members will be involved, and community health professionals, because many of the community health professionals know their community, know their people very well. They know what they have to do in order to deliver care, in order to deliver this knowledge about treatment options, because they're going to be perhaps some of our effector arms as well. So as we are explaining to the study group participants, the purpose of this research is to develop culturally appropriate teaching materials and tools for Indigenous people about the treatment options for failing kidneys. And these teaching materials and tools can cover a wide variety. They certainly will cover the different types of dialysis, both hemodialysis, peritoneal dialysis, home hemodialysis, kidney transplant, and conservative care. And once these teaching materials and tools have been developed, then we're hoping that we will test them in other Indigenous communities for usefulness and understanding. Next slide, please. So how are we planning to do this? Well, we're conducting a literature search as we speak for Indigenous education approaches and health literacy about chronic kidney disease and treatment options for failing kidneys. Then in partnership with Indigenous patients and families who have or are affected with chronic kidney disease, their unique learning needs and strengths will be identified. And then we will work with these participating communities to develop this suite of educational approaches for the Indigenous population. And these educational approaches obviously can take many forms, including paper, which may or may not be translated into local language. The elders and the people in those communities will tell us that. Storyboards, decision aids, videos, focus groups. And one thing that I've learned from another project is peer support. Indigenous peer support has been brought up many times about, this is what I would like. I would like an Indigenous person to talk to who's been through this journey themselves. So I think that that is going to be part of what we will be developing. So this suite of educational approaches will be applied, as they say, to several populations across Saskatchewan, British Columbia, and Northern Ontario. And the patients and families in these communities will have the opportunity to select among a suite of educational approaches, because not one approach will be one size fits all, that will best suit their needs. They'll be evaluated before and after being put into practice based on knowledge, so sort of like a pre-post test, which tools the patients are going to select most often, and then we'll do patient and family satisfaction surveys. And our work together, we'll provide a suite of decision-making approaches that will be tailored to Indigenous patients and families that are served by chronic kidney disease clinics across Canada. Next slide, please. So our progress to date in Saskatchewan is that to start the project off, we participated, several members of the project team participated in a sweat ceremony that was conducted by Elder George Laliberte, and who noted that protocol is the first thing we do. So the sweat ceremony blessed and prayed for this project to go forward in a fruitful manner. Our project team has deepened our knowledge about Indigenous perspectives and protocols, in large part with discussions with Elder George and with other Indigenous people and other elders, particularly in Isla Cross. The literature review has been begun. It's led by Lynn Jensen and Jeffrey Mena, the nursing professors, and our U of S liaison librarian, Maha Kumaran. Carol, Elder George, and Jack, as I said, traveled to Isla Cross in February to introduce the project to the mayor and the community elders. The community elders were selected by the mayor for their lifelong involvement in health issues. This project was very well received by the three elders that were present, and they expressed both their support and their willingness to help. Next slide, please. So our next steps now are application for ethical review once we've laid some of this groundwork. Of course, the literature review is ongoing. And with regards to Isla Cross, the project team is now preparing a memorandum of understanding to be discussed with the mayor and the elders. That's very important before we go back into the community. And the community elders will actually help identify community residents with chronic kidney disease who will be invited to participate in community meetings to discuss the project. Then for interested patients and their families and community health professionals then will be invited to sign consent if they are wishing to go ahead. And with regards to L'Orange, we're going to get our project off and running in Isla Cross first before we go to another community. So we're not likely to travel there till the fall because we'd like to have one project smoothly running before we go to another. Next slide, please. So with regards to our work in British Columbia and Ontario, I will be reviewing our progress in Saskatchewan with Dr. Below at the CANSOLV CSN meeting that's held in early May, and to hopefully further develop the BC plan. And as I said earlier, continuing to work with the Thunder Bay Division of Nephrology and Lakehead University College of Nursing with regards to our Ontario subcommittee. Next slide, please. So lessons learned so far. Well, progress is slow. Things have taken a lot longer than we wish, but I think it's very important that we do a lot of upfront work because that's going to serve us in good stead. That there is so much to be gained, really, by having an elder involved with this project team. I can't say enough about Elder George. He has been a stalwart and such a wonderful, humorous person to be on our project team. And we need to listen very carefully to what community elders tell us. It's, at this university anyway, it's been quite challenging to incorporate elders into our university system, particularly with regards to per diems, et cetera. And what we've learned is it would be really nice and useful to have a process manual, a practical guide for Indigenous protocol and procedures And so I think that we're trying to collate, Sharon is trying to collate, you know, what we should do when we're approaching Indigenous people with regards to how we want to move forward. And I think that will be very important for all of CanSolve. I've already talked with Mary Bopage, who is on IPERC, and I think IPERC is wanting to do a process manual. So I think that we would, as Saskatchewan, would like to be involved with that. I think all of us would agree in our project team that we have begun a very interesting journey together, and one which we hope will have positive impacts for Indigenous patients, families, and their communities. So with that, I'll stop and take any questions. Jack and I will take any questions.
Could I first mention that I just realized during the presentation that I made a cut and paste error. The title of the blue dimension in the medicine wheel should have been heart emotion. I'll fix the slide, and Graham, if you can make sure it's the revised version that goes up on the website, I'd appreciate it.
Sure, yeah, we'll do that.
So thank you, both of you, you know, it'd be great if people on the WebEx webinar or phone would like to ask questions. I think, you know, as you said, Joanne, it's complicated, and it's time, and it's like most things, the journey is the learning, and I think that's a really great example of how much you learn on the way. And I think for the patients and others on the call, it's an example of why things take a long time to get done, is to get them done right, you have to actually take all this time. Questions or comments from other people?
Well, it's Paul. I'd just like to compliment everybody who's been working on this, because it's very interesting information.
Thank you.
Yeah. Other questions or comments?
Hello?
Hello.
Hi. Hi, Marissa from BC.
Yeah.
I'm excited to hear about what you've been working on. Sorry for coming into the call late. I'm just working on a few different projects. In regards to the project of working with having a process of working with Indigenous people, I could really resonate with that, because when I started my chronic kidney disease, I actually had to have my auntie who worked in healthcare to break it down what it really meant to work with, you know, how to pay for all the medications and how to get all to the appointments, because it's overwhelming right off the bat. As for working with elders and providing honorariums, I work on a few projects with Aboriginal homelessness, and we have some templates of providing honorariums without having to make the elders sign the papers, but CanSolve can sign it, and it's still it is recognized federally too and provincially, so that so both don't have to worry about ruining their pensions and being able to pay them in cash. So I'm not sure who I share that with, but I could send that to the team.
Okay, that would be fabulous. You know, every university, unfortunately, has different rules and regulations, and so I'd be very interested, or we would be very interested in looking at that, and then perhaps having a dialogue with our university.
Yeah, and I think you're raising a really good point, all of you. I mean, I think that one of the things that, for full disclosure, we're all finding, you know, slightly, well, I want to say this in a nice way, disheartening, is the amount of bureaucracy that seems to be in the way of doing what all of us believe is the right thing. And I think that that's something that I really believe that the patient voice is really helpful for us, because I think it's really hard when the whole notion of the SPORE is to put the patient in the middle, and then there's not one system that we're interacting with that actually understands how to hear it.
Yeah, totally agree.
I just think it's, and one of the things that we're going to try and talk to CIHR about, you know, our funders, is to really help all of us navigate this. Because you shouldn't have to deal with all this bureaucracy. None of us should. It's not to say that the rules aren't there for really good reasons, and they were there intended for various reasons in another time and place. But we really need to work with, because I think it gets very disheartening for all the people involved, the patients and their families and the communities, if there's just always these barriers to getting stuff done. So I'm interested in all of your comments in terms of how we might work through that. I know it's not specific to your project, Joanne, but I think it's really important because, you know, 5 years goes by quite quickly because the first year's already done.
Yeah, absolutely. I think that's very important. So Marissa, Helen would have my contact information. If you wanted to send it to Helen, or Helen can send my contact information to you, whatever, and if you wanted to send it to me electronically, that would be great.
Good, that's a good way to connect. Other people on the call?
Hi, everyone. It's Kate Chong. Sorry, I put my little hand up on the screen. I don't know if anyone sees that, but thank you so much, you guys. That was a fantastic presentation, very informative, both on the project itself and then even some of the traditions and that from the Indigenous population is very informative just generally. So I think, yeah, there's a lot of different steps along the way, and it sounds like you guys are taking those appropriately and respectfully, so that's amazing. And I know we have some great people within our patient council that I'm sure would be eager to assist in different provinces than the ones that are currently on your schedule. Now, General, I know you stated for timing-wise, the first location will be first and then going to the second. What's your overall hope, I guess, timing for the project to not be completed, but kind of moving forward to the next stage?
First of all, we have to ensure that we have a memorandum of understanding with both communities, and then we will be identifying and inviting people to community meetings to determine their interest, then establish the study group or our patient partners, and then start to work on looking at educational materials for the treatment options. And some of this will likely mean a lot of teaching upfront from the project team about kidney disease and different kinds of treatment options for kidney failure. So there's going to be a lot of education, which I hope is a big good spin-off for the community, that those people that are involved as patient partners in the study would be able to take back to the community and do informal education themselves. But those individuals then will be helping us understand how we would educate and what kind of materials we need to educate Indigenous people about dialysis and transplant and conservative care. So the timeline, Kate, it could be anywhere from 1 to 3 years.
Right. Okay. No, that's fantastic. Well, do keep us, of course, in the loop, and as always, through our communications group and the patient council as a whole, we're here to support your project along with all the other ones. So
great. Thank you very much, Kate.
Great. I can't see the webinar, Graham, so you have to help me if people have their hands up or have are there any comments that people wrote in?
Yeah, we just had one from Sarah Gill, actually, so I can read that out maybe, and Joanne, if you're able to respond.
Okay.
So the question is, I'm just wondering if or when you start meeting patients to gather their input, if you foresee different needs for the different ages of the patients. For example, do you see different interventions or tools being required when someone in their 20s, for someone in their 20s versus what might be needed for an elderly person? And what would that mean in terms of development and how to generalize the needs, or will there be different resources for the different ages depending on needs?
Yeah. Sarah, that was a planted question, wasn't it? because the pediatric nephrologists are very interested in this project, and we had an initial conference, or I had an initial conference call with them, and so they're going to sit in on the Saskatchewan the subcommittee meetings every now and then. But that is an extremely good question, because needs are totally different from younger population to the older population. The younger population now may be more, tuned in to social media and all that kind of stuff, where the older population may not be. Now, I don't want to generalize, because I don't do social media, so I have no clue. So I think that once we start with our patient partners, we're hoping that we will have a diverse age group, that there will be a diverse gender, so there will be males and females, not just typically females have only been the ones that have been involved, but there will be males there, and that we will identify then the needs of younger people, maybe middle people, and maybe older people, and so I think that will come out. And if it looks like we're not getting the younger people involvement, then through my work, my day job, I'm the medical director for the chronic kidney disease clinic here in Saskatoon. We have something called a community health program, or kidney community program, and the nurse educator and patient educator that are employed with that do a lot of work with Indigenous youth. So my project team may engage in the youth in that situation. So I thank Sarah for bringing that up, because I think that is an extremely important avenue that we cannot lose. That has to be part of the project. I hope, Sarah, that I answered the question.
She says, yes, you did.
Okay, thank you.
Hi, this is Helen here, and I want to thank you, Joanne and Jack, right, for sharing this very exciting work. And I'm so glad that you're able to identify an elder who has been so helpful in helping you guys shepherd the way through and getting the project started. At this point in time, I'm wondering if you are planning to look for additional patient partners in Saskatchewan or BC or Ontario, and if that's the case, what are you hoping to, like, how would you like to involve them as part of the study team?
So in Saskatchewan, the patient partners will be actually the people that are developing these educational tools. So those people will be then in La Ronge and in Isle of Cross. We are looking to have a second elder on our subcommittee here in Saskatchewan. So we will be discussing amongst ourselves about approaching another elder here in Saskatchewan. With regards to British Columbia and Ontario, engaging patient partners there, I will be discussing that with Monica, and hopefully when we've identified the key leads in Ontario, we'll be discussing that with them as well. So we will likely be coming back to IPERC, to Kathy and Helen and Mary.
Thanks.
That's great. Yeah, and I think each province is set up slightly differently as well in terms of Indigenous health and access to various people. So I think the learnings from the different provinces and groups will be very important as well.
Right. And speaking with Mary at our KT committee meeting in February, Indigenous engagement in Ontario will be different than in Saskatchewan. And it's different again than in British Columbia because the populations of Indigenous people are different.
Yeah. I think the principles that you've outlined are great in the project, and it sounds like there's a lot of enthusiasm from all of the people involved. So I think it's up to us together to try and get rid of some of those bureaucratic barriers. I think there's two things, right? One is like the implementation science and the quote research. And I think people sometimes get the two things conflated and overdo the bureaucracy around the research and don't understand that, you know, in the real world, people try stuff all the time with no checks and balances and nobody says anything. You know, how do you actually, you know, engage people without getting them embroiled in kind of a bunch of, you know, filling out forms and sanctioning and all that kind of stuff, so.
Yeah, that's very true.
We've had another question come in. This one's from Heather Harris. She was wondering, Joanne, if you might be able to speak to how the two communities were selected.
Well, we selected them because the College of Nursing has very strong ties with Isle Cross and La Ronge. And we have some technology in those two communities that we can use. Because as I said, the drive from Saskatoon to Isle Cross is 5 hours, and the drive to La Ronge is 4.5. And the object is for the project team to go to those communities and develop these tools in the communities. So, you know, 5 hour drive, you know, and I really feel for my patients that actually drive those roads 3 times a week for hemodialysis in Saskatoon. And so we wanted to have the ability to have some technology that we could have meetings without us physically being there or without the patients patient partners having to come to Saskatoon. So that was one of them. And the other is that, so technology and the two communities are very engaged already with other things. Particularly Isle Cross has been engaged with some cancer and looking at Indigenous and Métis involvement with how cancer care is delivered. And La Ronge has very engaged, as I say, chief of the Lac La Ronge Indian Band, and we have some very good engagements with health professionals in La Ronge. So those were some of the reasons why we chose those. We chose northern Saskatchewan because the burden of chronic kidney disease is very high there. Heather, did I answer the question?
Did you?
Okay, it's 10 to the hour. Are there other questions that you can see there, Graham?
No, nothing's come in. If there is anybody who wants to speak, please, you can send it in a comment or just jump in on the phone if you're connected.
Okay, so I mean, sometimes people are shy to ask, but I think that it's fair to say that if you send your question to the CanSolve, the info@cansolveckd.ca web thing, or whatever the email address, then Graham can help to direct your question to Joanne and her colleagues, and we can get it answered after the fact. I guess I want to thank all of you for participating and for making the time. I know in the East it's evening, although with daylight savings, hopefully it's not too dark where you are. You know, I think it's really great to be able to share the background and the process as well as the actual specific research questions as you have, Joanne, and for all of us to be able to listen and comment. So thank you very much for taking the time and all of you for participating. And stay tuned for the next.
Yeah, thank you.
Thanks so much, everybody. Bye.
Thanks, everybody. Bye-bye.